Welcome to Beyond the Result, the podcast where we go deeper than the test result to explore how innovative diagnostic strategies can improve patient outcomes, support clinical decision-making, and strengthen healthcare systems. In this episode, our host, Angelo Rago, president of the Luminex division of Diasorin, is coming to you live from the ASM Microbe meeting, where diagnostic stewardship leaders from across the country gathered to discuss one of the most important challenges facing healthcare today: how to move diagnostic stewardship from a concept to a practice. In this episode, From Concept to Practice, Operationalizing Diagnostic Stewardship Through Flexible Testing, we'll explore how health systems can move beyond static testing paradigms and implement more adaptable diagnostic strategies that support better clinical decision-making, antimicrobial stewardship, and resource utilization. Angelo is joined by an outstanding panel of experts: Dr. Allison Chambliss, Diagnostic Stewardship Director at UCLA, Dr. Linoche Samuel, Microbiology Division Head at Henry Ford Health, and Dr. David Gaston, Director of the Molecular Microbiology Lab at Vanderbilt Medical Labs. Together, they will discuss practical approaches to implementing flexible syndromic testing, engaging stakeholders across disciplines, influencing provider behavior, and balancing clinical impact with operational and economic realities. Thank you all for joining. Let's dive into the discussion.
All right. Good morning, good afternoon. We're really excited to be here today at ASM in Washington, D.C. And I have an excellent panel with me today. And just to kind of continue to frame why we do this, just this absolute need to better serve patients and really understanding what value-based care might look like. Diagnostic stewardship is an amazing mechanism and operating model to really ensure that patients are getting the absolute best care possible, especially when we think about things like the aging population and factors that are impacting healthcare spend. I'll remind ourselves that 70% of clinical decisions require diagnostics, but yet the diagnostic cost is less than 4% of the operating budget, which is a very interesting dichotomy, because there's a lot of pressure on the lab to reduce cost, yet it has a massive value when we speak to the fact of caring for patients and understanding value. So that's the intent today, is to really dig into that a little bit more. Before I jump in the audience, how many folks currently have a diagnostic stewardship program active at your facility or your entity? Raise your hand. Roughly half-ish. Okay, good. Our goal is to scale diagnostic stewardship across the United States because it's the right thing to do. So let me jump in with my first question. And this is not a scripted session, although it's the first time that I've done this where we've been live. It's always been a screen, and a screen can always protect you. So we're jumping in the deep end of the pool today. So let's start with my first question for the panel. Before we get into strategies and workflows, I want to start with motivation. So each of you has spent a lot of time trying to make diagnostics work better in the real world. What was the moment that convinced you diagnostic stewardship had to become more than an idea, but really an operating model? Allison, I'll start with you and we'll just go right down the line.
So I'm a clinical chemist, and in the clinical chemistry lab, we're used to very high volume testing. So, diagnostic stewardship, or the idea of maybe reducing unnecessary testing, is very attractive because it can help kind of reduce the clutter, improve efficiency, improve turnaround times, make sure that we're only doing testing that's necessary. So that's one part of it. Another part of it is that there's constantly, evolving technologies, new technologies we'd like to bring in. And so, we don't have the resources to, expand our space or hire more staff to bring those in. So if we want to, be at the forefront and bring in those new technologies, we've got to be efficient with what we have and kind of make the space to bring that on. So those are just some initial thoughts, but many, many motivations for stewardship for sure.
Linoche?
Yeah, I think along with what Allison said, I think the other motivation that really drives me is the patient angle of this, because a lot of times we talk about right test, right patient, how do we best use the limited resources, and that is absolutely important. But we were hearing anecdotal stories of people who have insurance, but because of high deductibles, they are getting $1,000 copay bills, and not just for a 20 target panel. Even with a 4 target panel, you can get like a $600 bill sometimes. Yeah. And I think that, yeah, we're scientists, we're microbiologists, we're chemists, but we still have a responsibility to the patients to make sure that they are getting value for that test result. So I think that absolutely needs to be part of the diagnostic stewardship conversation.
Absolutely. David?
I think it's our ethical responsibility as medical directors to know what downstream negative effects there could be to the patients we serve. Angelo, to your question, what was the moment where things clicked? The moment for me was when I was an internal medicine resident and I was caring for a patient with fever of unknown origin. And I went through and clicked every single box that you could possibly click for any particular test because I had no idea what I was doing. So, I'm trying to be helpful. I'm trying to help this patient, but ultimately I just order a tremendous amount of unnecessary testing that much of it took weeks to return. And ultimately, I don't remember what the diagnosis was, but it wasn't anything on my list because I didn't have a list. I didn't have a differential. I just said, this person's sick. Here's a button I can click. Okay, I'm going to click. And that was bad medicine. So, to be able to practice the best medicine we can, to be able to provide the highest quality care, the highest value care, because we are practicing patient care. And it's to the patients that we're responsible.
And I think this is where the challenge comes in. When a physician is sitting in the ED or sitting in front of a patient, you want the best answer, the most complete answer that patient needs to hear. And there was one of my guests who told me a story, and I don't think that the story was actually broadcast, but she told me a story about a mom coming in with a child with a bad cough in the ED, and a baby. Both had the cough. They ended up running a very large syndromic panel. That mother, a month and a half later, got a $6,500 bill, and her call to the lab was, I cannot make my mortgage payment because of what you charged me. And that breaks my heart. It really breaks my heart because I don't think the clinician was trying to do anything wrong. They're trying to get an answer. This baby could have an issue, the brother, right? So you're trying to respond appropriately to the situation, and the cost is just outrageous, right? I mean, we all have health insurance, and we still get this additional bill that says, but this part's not covered. And some of us can afford it, and others can't. And I think this is the piece where it's not just about diagnostic stewardship as a concept or value-based care as a concept. It's the impact on the patient. So diagnostic stewardship means different things depending on where you sit, right? And all of you actually sit in different roles. So if you think about the appropriateness of ordering and how to execute this, David, starting with you, how do you see this being tackled?
Some of it has to do with making good relationships with the people who are on the front lines ordering, so you can understand both what their needs and challenges are. A way that we've tried to tackle this at Vanderbilt is recognizing that folks who are ordering the tests don't have the same understanding of potential costs and ramifications to the patients as we in the lab do. So we've attempted to automate some of that stewardship. So for outpatient gastrointestinal panels, we're making sure that there's logic running in the background that's checking ICD codes, that's checking later CPT codes. And if if a well-meaning provider is attempting to order a panel that has 12 or more targets on it, they're going to be, and they're not an immunocompromised patient, they're getting a message that says, hey, this might not be reimbursed. Right? We're not telling them don't order this. That's fraud. But we're saying, hey, this might not be reimbursed. Can you look back to say, to make sure that you're ordering the test that you really, so just that moment of triggering some extra thought and also triggering a moment to say, oh, there may be implications to this that I don't understand.
Yep.
Just to piggyback on that, I think that one of the things that I tell residents all the time is most providers have far too much faith in lab results, right? There's a nuance there, and so if you're surprised by a result, that means you probably shouldn't order the test to begin with. But I think when approaching diagnostic stewardship, I think we have to think about it. You mentioned, Angelo, that the lab represents only 3-4% of the total budget, right? So if you are engaging in it from the perspective of lab savings, whatever costs you save from the institutional perspective are going to be minuscule, right? So we have to think about what can I do to change provider behavior, change resource utilization, change outcomes for the patient. I think that needs to be our perspective, because that's where you can get really institutional support, attention, and if you change the utilization of other diagnostic tools, MRIs, X-rays. So I think when we try to approach diagnostic stewardship, I'm not saying we shouldn't engage in lab saving exercises, but I think that what we should look at is from the perspective, what can I do to make the life of the ED provider easier, else for the patient, or the ICU doctor? And you want those champions, as he was saying, as David was saying, you want those champions on board with the conversation, because I don't pretend to understand what their situation is like. Just because the test is the wrong test, that doesn't mean it doesn't have value to their workflow. So I'm approaching it strictly from a very narrow perspective, and I think we need to make sure we understand their perspective as well, and not look at it strictly as a cost-saving exercise.
Yeah. Allison?
I'll add, I think a lot of it is about intentional onboarding of these tests. I think historically, when our clinicians wanted a new test, or there was a new technology, we saw ourselves as kind of the analytical validation part and the operationalization part of it, and didn't think too much about the billing or what happens downstream, especially when it comes to something a bill that the patient might receive. And so now I think we're thinking more forward about bringing on new technologies, thinking the complete downstream effects, looking at payer policies for common payers in our patient population, and understanding and trying to, it's complicated, and you can't always guess what the insurance companies are going to cover and what they're not going to cover, but trying to understand, the likelihood of something being covered for our patient population, and if there are stipulations from the payers about certain criteria that have to be met, making sure that those are communicated well to our clinicians, and then maybe even building something into the EHR order system about, do we want to require the provider, do we want to have logic to check the ICD-10 diagnosis codes? Do we want to have them check off the clinical indication in the order window? Just trying to do a better job at anticipating some of those issues and getting ahead of them so that we don't end up in these situations that you've described.
So I'm gonna divert for a second. You guys are gonna be mad at me later. But you said something very important that I think all of you touched on a little bit, that I want to go a little bit deeper. This issue of the lab and its cost versus its value is really misunderstood in the hospital system. And one of my dreams, but I'm too old for this, is to go run a hospital system. Just because one of the things I go after is, where are the economics? What I seem to run into is hospitals are a group of functions that somehow work in silos, and physicians have to figure out how to manage it. And I really believe that if we looked at the total cost versus just the lab cost, what the treatment cost is, what the impact does on the patient, if we looked at it from an impact perspective, the message would be super clear. So actually, I have a question that was supposed to be later, but I'm going to pull it forward, which says, if you had a few minutes with your CEO or CFO, how would you justify diagnostic stewardship without using microbiology language? What do you guys think?
Give me a go for it.
Sure.
So I think that one of the things that diagnostic stewardship runs contrary to what people expect of us. You want growth, constant growth in volumes, growth in your numbers, blah, blah, blah. So you're actually actively trying to cut your numbers. And then when you look at it from a cost perspective, when you do fewer tests, suddenly your cost per unit goes up. So you now appear to be inefficient because you did the right thing, right? So this is a failing argument or failing approach if you look at it just from a lab perspective.
Yeah.
And so we've had that metric used against us. Your cost per test is higher, but I did the right thing. And then that's being used as a reason to monetize the lab, outsource the lab, all those things. So you have to engage with the institution and with your providers so they understand what the value is that diagnostic stewardship brings. And you need to know what that value was. And you have to have ongoing monitoring. I initiated, we rolled out T2 Canada years ago. We no longer have the test. But when we rolled it out, we had an ongoing monitoring program with the help of our colleagues in pharmacy and infectious diseases, because no way we could do it ourselves. And we were able to capture that our opening strategy was a failure. But down the road, we show reduction in antifungal utilization, reduction in time spent in the ICU. And if you don't have that data, then the fact that we reduce utilization will actually work against us. Can work against us.
Understood. Allison, you want to go next?
Yeah, I will. First of all, I'll say it'll be easy for me not to use microbiology language. I don't know any microbiology language, but I'll try not to use chemistry language. But it's exactly that. It's having outcomes measures that are not test volumes. And yes, if you can save cost, highlight that, because your C-suite will really love that. But what outcomes measures can you link? And so with every stewardship project that we do, we define kind of a lab-based KPI, key performance indicator, outcomes measure. But we also try to have at least one clinical outcomes measure. So it could be length of stay, turnaround times, help with throughput, especially if we're thinking about our emergency department. Thinking of downstream impacts, like if a test is going to lead to a consult or a biopsy or another procedure, if we can show that we are reducing unnecessary, more high cost procedures than just lab tests, that's another one that we would think about.
David?
Those are all great thoughts. Aligning what are the values of the microbiology lab and aligning what are the values of the C-suite is an important part as well, because we think about medicine in completely different ways. And I will go so far as to say, I think the C-suite is trying to do the same thing that we're trying to do, which is do the best thing for the patients we serve. They're looking at it from a way of how do we use metrics that are most applicable broadly across hospital systems. So things like time from admission to diagnosis, time in an ICU, time in an ED. I mean, all these metrics about just getting people out of the hospital. So to be able to link those outcome metrics with what the C-suite is looking for is one important way to do it. And then also just defining the terms that we're, what do we mean when we say value? What do we mean when we say cost? I mean, when I'm talking about value, I'm talking about a fairly specific equation that is unitless, but is the quality of a service plus the impact or the utility of a service divided by the cost of that service. So if you have an expensive service, but it's very high quality and impactful, there's still good value there.
Exactly.
Whereas if you have a service that is, that's cheap, but that doesn't do anything, well, that's poor value in that sense.
Exactly.
So, and while we're talking about terms, I should also correct a term that I used a moment ago, which was the term fraud. What I was getting at with our automated diagnostic stewardship system with outpatient GI panels is that we can't tell providers which IDC code to use. That's illegal. But if there's a mismatch there, we can say, hey, consider the testing that you're ordering, because it's not, it may not be what you're trying to order.
Makes sense. But I'm going to go down this data path, because all of you have lots of data. And I believe that there's a very significant statistic. It's well over 80% of AI pilots in hospitals are failing. And yet, good management of the data that the hospital system has, not just the lab, would actually create the case for some of this value orientation. Is any of that happening in your systems? Is there an effective use of AI? Because some of it is it's tons of data, and you need to really understand how to teach the algorithm to look for the economic piece that makes sense, to your point, right? About, in this case of this patient, it might be that a more expensive test is the right way to go, whereas a different patient, it's a different type of test. And I don't want to link it just to syndromic testing. It's a broad spectrum of testing. So what do you guys think about implementation of AI within your hospital system? Is there any link to this health economic piece at all? Who wants to start?
It sounds like a great idea. Vanderbilt may be doing this. The VCLIC, which is a Vanderbilt University Medical Center for, I'm going to get the acronym wrong. It's a really excellent biomedical informatics group that works with data that's generated by the laboratory as well as data that's generated through just routine clinical care, and asks uses some very powerful tools to ask great questions. I would not be at all surprised if they're working with health economists at Vanderbilt to be able to ask these kind of questions. I'm just ignorant to what they're doing, but it's a great thought.
Yeah, I think it's more about promise. So like, they keep sending me emails saying that there's these tools available and you use them, but we're still relying on old school dashboards, databases. And I think we have softwares, for example, that can flag. This is the bigger challenge. As our health systems get bigger and bigger, what we're seeing is that diagnostic stewardship, what I assume is happening, is not really what's actually happening and it might be that one community hospital is doing something completely different from another community hospital. So we had one community hospital suddenly had a surge in large panel, respiratory panel usage. Turns out they were using it to rule out mycoplasma pneumonia because that was the only place they could find mycoplasma pneumonia, right? So using a 20 target panel to rule out one target, I'm not even sure it rules it out. So it's those things that I think that I happened to look at that data and I found it, but it had been going on for months.
Yeah.
So those are the things that I would love to see AI capture, ask questions that we're not asking, see, well, here's a trend shift over time from what was the norm for the last 5 years. Have I seen that happening? No. But would I like to see that happening? Yeah, that'd be great.
Allison?
Yeah, similar here. We're not using AI for diagnostic stewardship purposes, at least that I know of. But we do have a lot of data, and that data can help inform stewardship priorities and projects. I mean, when I think about AI, I guess, one thing that comes to mind is that I feel like maybe has gotten close, but still is not, doesn't seem to be working that well, are these sepsis prediction models. But no, I don't think we're actively using anything AI-wise. It's more about looking to the future and seeing if anything's going to be well validated enough to implement in the real world. Yeah.
The validation part, right? And that's not trivial in such a situation, because no matter what AI model you're using today, you've got to take a second set of eyes to look at it. And I've played around with having a model look at another model and look at the other one and try to see if the answer comes back the same way. And next question is going to go towards barriers, but because when I think about AI and I spend some time at these AI and healthcare conferences, some of the experts are saying the reason these pilots are failing is not the technology, but the people. That it's an organizational issue within the hospital system versus a technology issue. Now, that's always easy to say when you're the technologist, right? But the reality of it is, if you can't implement the technologies for those people, then it's not going to work, right? That's why it's failing. But if we think about the barriers to diagnostic stewardship at a daily level within your organizations, what are those key barriers? And are there things that you've been able to do to kind of move them along? David mentioned talking to the frontline physicians, but what other thoughts do you guys have when it comes to barrier removal?
Well, I think for us and for me, there's so many potential opportunities and not enough time or bandwidth or people to focus on them. Our institution has invested well in diagnostic stewardship. I'm the director of laboratory stewardship. We have a program manager for our stewardship program. We have a committee. We have multiple levels of committees, but we're limited just by what we can accomplish in a certain amount of time, how many projects we can work on in a certain amount of time. And I think we've had many ideas come to us, and we kind of have to prioritize them. And also, we can't do them alone. We really need clinician champions to be effective. And so, we do have some, but, connecting with those clinicians and finding the time to sit down with them and to map out, an appropriate stewardship intervention. It can be done, and we have done it successfully, but it takes a lot of effort and time and expertise.
Yeah, I think this is always a challenge for all of us, is getting access to the informatics. So the informatics people, I think, is a big resource.
Yeah.
Until AI comes along and magically solves the problem. And we've been able to have some success there. Just even small things like, okay, you rolled out a TB PCR, capturing the reduction in negative pressure room utilization because you rolled out the TB PCR in the pre and post analysis, right? Not that I'm going to publish it, but to show administration, this is an expensive resource. But to do that probably took me a month of like going through different rounds of people telling me it couldn't be done, until I found the person who said it could be done. Right? There's always a way to do it.
Yes.
It's a matter of finding the person who can get it done for you.
Yeah.
And so we talk about outcomes data, but that is the hardest part of this.
Yes.
And it's still a people problem, is getting the people to do the print. So again, this goes back to I would say our allies in pharmacy and infectious disease, who are fellows who are incredibly capable for us, who've been supportive in leveraging some of this. But even the Epic side, we've been able to get Epic analysts to pull data for us.
Yeah.
As in this case, with the TB-PCR, we were able to show significant reduction in negative pressure room reduction, right? It's a standard assay, but to show that, everyone uses it, but show that we made that change. We saved the institution this amount of money. That gives value to what you're doing.
Absolutely. David?
I think there are two barriers that I see a lot, fatigue and understanding. And so from the fatigue standpoint, you have providers who have 30 minutes to see a new, very complex patient.
Yeah.
And that's hard.
Yeah.
So it's much easier to have an order set pre-selected that may have testing that is not necessarily applicable to that patient, but just to click the new patient order set and to just not, you're already so fatigued, the extra thought it takes to be able, or the extra energy it takes to be able to think a little bit more, that's really asking a lot.
Yeah.
On the other side of that, the understanding portion, you may have providers who are very well-meaning but don't understand the test that they're ordering. So two quick examples there, one of which is our HSV1, HSV2, VZV assay that a lot of outpatient providers were ordering because they thought it was screening for HSV1. There's not a screening test for HSV1, right? This test is for lesions or for patients concerned with viremia. It's for patients who have symptoms. It's not to screen, hey, could this patient be infected with HSV1? It was just a complete misunderstanding of the use of the test. Then my whole wheelhouse is next generation sequencing and metagenomics and all that. And so seeing folks who really see the power and potential of these advanced diagnostics, but don't understand the pitfalls. And so a bit of understandable magical thinking comes into it, where some of these tests just can't do the things that people think they can do, but they order them anyways, and then don't quite know how to interpret the results, which is another very important part of diagnostic stewardship. It's not just about saying, hey, we've got to make sure that you only order the right test on the right patient. You also have to close that loop to say, when the test has been ordered and you get results back, how do you work with those providers to be able to look at the results, understand them better, and then order it better next time?
Yep.
If I can just follow up on that, because Dave raised a really important point, especially as you go through and you see all these new technologies coming out.
Yeah.
We saw this, again, going back to my example with T2, where we rolled it out and people got really creative with how they used it and the context in which they used it.
Yeah.
And what happened was, when they started using it in patients who were not appropriate because they thought, well, this is a great new tool, let me use it, and we didn't put appropriate safeguards in place, the test did not perform as intended. And so we saw a significant spike in false positives. And when we went back and aggressively pushed diagnostic stewardship, it fell within acceptable parameters, right?
Right.
So this is really important that you go back and make sure people are using the test as intended. And I think stewardship is a big part of that.
Yep. That makes sense. I want to turn it to the audience, because I'm sure those who are in the process of trying to do diagnostic stewardship in their facilities maybe are facing additional barriers. Is there anybody in the audience that might have a thought, a question for us regarding diagnostic stewardship in general or barriers?
Thanks for this great discussion. So I was wondering, when it comes to communicating with frontline providers and educating in the case where maybe understanding is lacking, what are some strategies that you guys have used and had good success with, and what are some strategies that maybe don't work very well and maybe should be avoided?
Great question.
Do you want to go first?
Yeah, I can go first. So, well, we've tried a couple different ways. I think where we've been most successful is actually starting with the leadership of a particular specialty or provider group and getting their buy-in first, and then asking them, what's the best way to disseminate this information? We found that different clinic locations, different specialties, they have different styles, they have different ways, maybe faculty meetings or memos, they have different ways of communicating with their own specialty. And so going to that leadership first getting their buy-in of like, yes, we all agree that this is an issue and this is the type of communication we want to push out. And then talking about, okay, what's the most effective way? Sometimes it's me going to an oncology faculty group meeting. Sometimes it's sending an email memo to a defined group of providers. Sometimes it's actually putting something in the electronic health record system, at the top or side of a particular order of a test. So it varies, but those have all been successful ways depending on the context.
Understood.
Yeah. Everything she said, the other thing that I found really successful is nursing education. So I've been a regular attendee at our Nursing Education Council, and they are very structured and aggressive in pushing on nursing. And then the providers will be like, well, my nurse is telling me this. I'm like, yep, that's right. So that's, I think, also an effective means of communication. Definitely engage with them.
Yeah, yes, and to all of that. At Vanderbilt, we have a laboratory-focused stewardship team led by Dr. John Tucci. There's an institutional stewardship team led by Dr. Ritu Banerjee. Those teams get input from all different specialties, and then we're also able to go through and identify what are issues that we see, and then work with those individual specialties to make changes. So we've gone through an initiative about erythrocyte sedimentation rate, ESR, and just where does an ESR order actually need to be? Where is that clinically impactful and significantly diminished use of ESR? I mean, when I was trained in medicine, you're just like, oh yeah, ESR, it's an inflammatory marker. It helps. No one knows. You have to sit at vial of blood on a table and then watch the erythrocytes sediment, and it's a lot of work from the lab side. Things that don't work are just sending out emails broadly into the ether of your institution about we think you should do this or that, right? That doesn't work at all. And then if you find something that's really targeted a few times, this has been kind of fun. I'll pull data on a test that I think is being unintentionally misused, sort it in a particular way where I can see which either specialties or even sometimes which providers are over ordering particular tests. And when 70% of all tests are coming from one person, it's kind of easy to then be like, hi, I'm David. Let's get a cup of coffee, right? Like let's talk about this test and how you think it works and what you think's happening. And that builds relationship, right? It's not coming in just to be like, no, you're doing it wrong. But to come in to understand where there may be a mismatch, and then, then you make a friend in the institution.
Yeah, really want to emphasize that targeted communication, much more effective than these broad, we have these epic emails that go out with updates, and sometimes we do put our stewardship stuff in there, mostly to cover ourselves. If someone comes to us later and says, I didn't know that I wasn't allowed to order this, like we can say, well, we did send an email last week. So that helps, and I think that's necessary, but then you have to go beyond that. Use the data to find out who is your target audience. It may be a huge group. It may be one person. Use the data to do some targeted communication.
So you got another question. Just a closing comment on this. For all of you in the audience, is there anyone, I want to do the positive side. Who believes that diagnostic stewardship will and is valuable to impact patient care? Let me see a show of hands. All right. So 100% of the audience believes that, yet 35% of the audience, based on my math on the hands earlier, have implemented. And the reality of it is that you're creating change in your organizations. I've been in the industry 40 years. I've changed a lot of companies. Change is hard. But it's like Wayne Gretzky said, to be a great player, you got to skate to where the puck is going to be. Diagnostic stewardship is required for the future of healthcare and serving patients correctly. I've heard it from the panel. You need to persevere in your organizations because there's always going to be barriers to implementing things like diagnostic stewardship. You can't give up. You got to keep pushing and keep pushing for what is right. You said that, right? We need to continue to push for what is right. And I always say to the people I work with, my integrity is more important than money. If we're doing the right thing, the money will come. If you focus on making money, you're going to make the wrong decision. Taking care of patients is the right thing to do. You had a question.
Great. So I was curious, I'm still a trainee thinking about moving into like a new position. If you move somewhere that doesn't steward many of their tests now, how do you bring that up? Because you've talked a lot about what's worked the best, but when you go somewhere who's not doing much, you can't, I wouldn't envision jump in and start doing everything heavily. So how do you recommend going about that?
Interesting. Good question. Go ahead, David.
This is a place where I think ASM is going to be helpful. Dr. Laura Filkins is directing a diagnostic stewardship group within the ASM Health division. And that group is going to be developing some very helpful resources to be able to say, how can you do exactly what you just described? If you're stepping into an institution that does not have formalized stewardship, step one is, and so very excited to see what they're going to be making. Practically, step one is just talking with people, getting, finding out who's interested, who understands what you mean by diagnostic stewardship and what other people may think you mean when you say diagnostic stewardship. Going with some of this data that was talked about earlier in terms of just the value of not doing testing for everybody all the time. I mean, it's very akin to antimicrobial stewardship, and there's great data about best use of antibiotics. Broad testing is not needed for everyone in the same way that broad spectrum antibiotics are not needed for everyone. And that logic kind of applies both ways. So and then just start a committee. Just say I'm going to start this committee. I'm going to give it a pithy name and start some Teams meetings or Zooms meetings or what have you. And they're the first Monday at 10 o'clock in the morning, and then start inviting people there. And then you just build your own stewardship committee.
So if I can just real quick piggyback on that, the CDC has a diagnostic standards of excellence that are really useful, and a big portion of that is diagnostic stewardship, alongside with the resources that Lab Practices Committee has published on behalf of ASM. But in addition to that, I would leverage existing resources. So your organization probably has like a antibiotic stewardship subcommittee or a committee of some sort. You can start there because the people are already there, right? The different stakeholders are already there. And so that may be a point where you start your diagnostic stewardship. That way you also have the cover of a hospital committee or subcommittee that supports your decisions. So when someone comes in and says, oh, why did you do this? Well, it was the committee decided this, right? So that's a great way to start. And then you can branch out from there once you build out your program.
And I'll just add, quick wins, build on quick wins, pick one test, one thing that you're passionate about that you see could use some improvement. Maybe some people can gather around you to help, even if they don't. If there's something you can do just to find a quick win, build on that. Once you've done it, share it broadly, get people excited about more, and just start building gradually.
I like that idea, quick wins. Was there one more question?
I have a question. Okay. So if we go back for a moment to talk about clinician buy-in and really working with your clinicians and other members to develop these tests. If we think about Diasorin and the new FDA-approved GI test on the Liaison Plex, how would you work with your clinicians to design these GI panels and really make sure that this works for the patient institution?
Yeah, I think that the key is identifying which panel is appropriate for which physician group, right? And not everything is for everybody. We don't use a large panel for GI testing at all at our institution because we feel like that there's a lot of issues associated with that. So we know, for example, going back to a different example, which is HPV, we went to our OB providers and they were not interested at all in HPV self-collection. So we thought, well, maybe no one wants it, but primary care is gung-ho about it, right? So it's about finding the right cohort and of group and finding which one it's most appropriate and then targeting that group. So we used permissions within Epic. So certain providers can access certain tests, others can't. And that is signed off by our stewardship committee. So it's not a lab decision. It's a stewardship committee decision that certain providers will have access, others will not. And then we make sure, as Allison said, leadership of those divisions are engaged, champions of the divisions engaged, so no one can say they weren't informed because I'm not reading their emails, they're not reading my emails, so there needs to be some kind of communication, right? So I think those are the things I would take, those are steps I would take.
And in working with the clinicians who are seeing the patients to help design how this works, we went through a similar process with a different FDA IVD certified outpatient GI testing on multiple panels, and put those panels together in different ways that providers can see, working with infectious disease groups to say, hey, what do you think is most appropriate for pediatrics? What do you think is most appropriate for immunocompromised? What do you think is most important for travelers? What do you think is most important for acute diarrhea versus chronic diarrhea? And put all those orders together in a way where providers can order, what they need, but also in the context of only getting up to 11 targets, which from putting on my provider hat, I never understood any sort of CMS rules when I was practicing patient-facing medicine. Now I put on my laboratory director hat and I understand, there's certain CPT codes that are up to 5 targets, then there's 6 to 11, then there's 12 or more. And if it's 12 or more, then you have to have ICD, thank you. ICD-10 codes that are both for diarrhea as well as for immunocompromised. And so all of this stuff in the background for CMS to see medical necessity, that's not understood on the clinical level at all, because they understand how to care for a patient and how to do that well. And so being able to design some of these panels in ways that are both actionable and helpful, and also, or maybe not design panels, make panels available in a way that are actionable and helpful, and also don't unintentionally put huge bills on patients. And what I see providers doing is ordering the testing that gets up to 11 targets, right, all the time. It's like, how do you get right up to that edge? Which is still, we got a ways to go.
We're also huge fans of nudge comments. I think when I started on microbiology, nobody would read our comments. Now they call me and ask me, where's my comment? So I think nudge comments, and we've actually got data to show that comments to guide the provider on what to do next, how to treat, what test to order, have a lot of value and actually change behavior. So that's another strategy that goes hand in hand with diagnostic stewardship.
Excellent. Allison, anything to add? No?
I'll let the micro directors handle that one.
Okay, so we're turning the corner as we go to close. My typical question at the end is, how can industry help in the mission of diagnostic stewardship into the future? But you can choose that question, or you can choose, if you feel we missed something today that you feel is important in the mission of diagnostic stewardship, choose which you'd like to cover. Who wants to start?
I can start. I think the biggest challenge, of course, is collecting the data, right? I know ASM and ADLM are actually working together to try and put together some guidelines on how to generate outcomes data, but it's still the hardest part of this is generating the data to justify your stewardship approach or to demonstrate the value of what you did. And it's not easy. I'm not going to sit here and pretend that it's easy. A lot of times it's like 6 months of work just to get data on one particular study or one outcome. So I think having people support you in that, and in our case, I think it's pharmacy ID, but if we had emergency doctors, for example, support us in those things, that's critical. But I think even from an industry perspective, maybe supporting efforts to generate tools that can help us pull those. Maybe it's an AI tool that can generate that outcomes data is really critical.
Excellent.
And I'll jump on that and say, I think the biggest way that we can practice stewardship at scale is really exactly what we're doing here, is talking with other institutions and sharing best practices. I think a lot of us initially were really reinventing the wheel in taking these problems on and taking a lot of resources and time and data to do so. And chances are, there's definitely differences between our institutions, but there's also a lot of similarities. And as we bring on new tests, I think we're asking ourselves a lot of the same questions. So if we can do more sharing of best practices through ASM, ADLM, and other ways. And I think industry can help us with that too for their particular tests, connecting us with other institutions that have brought on the test and, maybe learning about different ways it's been implemented, certain provider restrictions or provider communication. It may not be an exact match, but it can be something that another institution can take and build off of. And that's the best way that we're going to do this at scale.
Excellent.
And to what industry can do to support diagnostic stewardship, I think the most important thing right now you can do is ask that question. Yeah. It's a great question. And the first time they heard that question asked from an industry representative, it off-footed me in a good way because I didn't think that was a question that would come from industry. Yeah. And it got my wheels turning in a way to say, oh, okay, I've always thought that was the responsibility of the hospital system and those in a local level, but to be able to think, oh, stewardship is the responsibility. Stewardship's the responsibility of anyone who uses a resource. So if if we're partnering to be able to say, what could we do? I think there'll be some really great answers that come out of that. So just asking that question. And if there's, if you're kind of met with a blank stare, that's okay. The wheels are turning. But yeah, what can industry do for diagnostic stewardship in and of itself is a great question.
I think there's an opportunity for industry to work with the ASM even deeper. I know there's already connections there, but I'd love to have a vision of a diagnostic stewardship conference where really you're bringing in all kinds of disciplines together to solve the problem. In best case, have use cases, best case, have all kinds of ways, almost like you're doing a Harvard class, right? You have a paper you can review, you see an implementation, then you have people who are coming who are in the process, and it's a growing and building opportunity, all focused on the patient. So we'll have to see if the ASM wants to get in on that aggressive thought. Listen, I've really appreciated everybody here today. The panel, thank you so much. You guys did a great job. I really appreciate this. We are going to make an impact in patient care. It may be challenging, but I believe we can. I'm committed to it. We are committed to it. I know my panelists are committed to it. We will make an impact. Thank you so much for coming today.
That wraps up today's episode of Beyond the Result, from concept to practice, operationalizing diagnostic stewardship through flexible testing. A special thank you to Dr. Allison Chambliss, Dr. Linoge Samuel, and Dr. David Gaston for sharing their expertise and real-world experiences implementing diagnostic stewardship across diverse healthcare settings. If you enjoyed this episode, don't forget to subscribe, share it with your colleagues, and follow Beyond the Result for more conversations with leaders who are shaping the future of infectious disease diagnostics and laboratory medicine. Thank you for listening. And as always, stay curious, keep asking questions, and keep pushing the boundaries of what's possible in diagnostic medicine. We'll see you next time.